Statins are the cornerstone of cardiovascular risk reduction, however muscle-related adverse events remain the leading cause of therapy discontinuation. In this video, I'll focus on how to recognize clinical features, understand the time course, and make a prompt diagnosis to maintain adherence and prevent adverse outcomes. To ensure timely intervention, the first step is understanding the clinical features of statin-associated muscle events. Statins are associated with several muscle-related effects, including myalgia, which is associated with unexplained muscle discomfort often described as flu-like symptoms. The spectrum of myalgia complaints includes muscle aches, muscle soreness, muscle stiffness, muscle tenderness, and muscle cramps with or shortly after exercise. These muscle symptoms occur without significant creatine kinase elevations, and CK level is usually within the normal value. Another muscle-related effect of statin is myopathy, which is defined as unexplained muscle pain or weakness. Myopathy is not necessarily associated with elevated CK level. However, can be sometimes accompanied by a CK greater than or equal to 10 times the upper limit of normal. Myonecrosis is another clinically important muscle-related side effect of statin, often associated with an acute renal failure secondary to myoglobinuria. Therefore it is called as a myonecrosis with myoglobinuria or rhabdomyolysis. CK elevations may be represented as follows: mild, when levels exceed 3 times the upper limit of normal; moderate, when levels reach or exceed 10 times the upper limit of normal; and severe, when levels are 50 times the upper limit of normal or higher. Another clinically significant, but rare muscle-related side effect of statin is an immune-mediated necrotizing myopathy. Patients with an immune-mediated necrotizing myopathy typically have mild to moderate symmetric proximal muscle weakness. Rarely, mild joint pain or rash may be present. This clinical feature is associated with elevated CK level plus the presence of antibodies against hydroxymethyluteryl, HMG, CoA reductase responsible in regenerating muscle, and possibly other proteins. With the clinical features clear, let's move to the mechanism. The overall mechanism of statin-associated muscle-related adverse effects is uncertain, but several pathways are implicated. 1. Mevalonate pathway disruption. Statins alter the mevalonate pathway, which may affect downstream metabolites essential for muscle function. 2. Sarcolemmal changes. Statins may modify the electrical and structural properties of the sarcolemma, influencing calcium ion flux and contributing to muscle symptoms. 3. Reduced ubiquinone. Lower levels of ubiquinone, a key component in mitochondrial energy production in skeletal muscle, may impair cellular energy generation. 4. Concentration-dependent toxicity. Higher circulating concentrations of active statin increase the risk of myopathy and rhabdomyolysis. 5. Immune-mediated mechanism. Immune-mediated necrotizing myopathy is thought to result from an autoimmune response, characterized by the presence of anti-HMG CoA reductase antibodies. After understanding how these effects occur, let's discuss usual onset of muscular adverse effects. Statin-associated muscle symptoms typically have a delayed presentation, most often emerging within the first few months of therapy, with the highest risk occurring during the first year. In contrast, immune-mediated necrotizing myopathy generally appears after prolonged therapy, with onset usually occurring after approximately 2 to 3 years of statin use. Now let's see the risk factors contributing to statin-related muscle side effects. Several factors increase the risk of statin-related muscle side effects, including first year of therapy, drug interactions, for example interaction between statins and itraconazole, older patients, hypothyroidism, pre-existing muscle disease, kidney impairment, females, low body mass index, heavy exercise, specific populations such as Asians, and higher HMG CoA reductase inhibitory activity. Statins differ in their HMG CoA reductase inhibitory activity, highest with Rosuvastatin, followed by Atorvastatin, then simvastatin, with pravastatin and levastatin showing similar lower potency, and this gradient contributes to the varying risk of muscle-related adverse effects across the class. With those risk factors in mind, let's now look at how to diagnose muscle-related side effects from statins. When evaluating a patient for possible statin-associated muscle symptoms, diagnosis begins with a careful assessment of clinical symptoms. Statin-related symptoms are typically bilateral, proximal, and involve large muscle groups such as thighs, hips, shoulders. A CK elevation helps confirm true muscle injury and guides the urgency of management. Measure serum CK in suspected severe muscle injury. Persistent or very high CK levels, for example greater than or equal to 10 times the upper limit of normal, raise concern for myositis or necrotizing myopathy. The timing of statin initiation is another critical clue. Review the history of statin initiation, dose increases, or drug interactions, since symptoms commonly develop within the first few weeks to months of therapy, making timing a key diagnostic clue. Another diagnostic method of statin-associated muscle symptoms is resolution of symptoms after statin withdrawal. This is one of the most useful diagnostic steps to observe whether symptoms will improve after statin withdrawal. A clear resolution strongly supports statin causality. To make the diagnosis more structured, tools like the Statin-Associated Muscle Symptom Clinical Index can help distinguish true statin-related symptoms from unrelated musculoskeletal complaints. This index evaluates factors such as symptom location, timing, symmetry, and rechallenge response. And in the rare scenario where the diagnosis remains unclear, especially in patients with persistent weakness, very high CK levels, or suspected autoimmune necrotizing myopathy, a muscle biopsy may be considered to evaluate for alternative myopathies. Putting these elements together allows clinicians to make a confident, evidence-based diagnosis of statin-associated muscle symptoms. Thank you for watching. If you found this useful, consider subscribing to my channel for more clinical updates and practical tips.